Peter Barlis here, cardiologist. Now today a much anticipated video and discussion about all things statin drugs. Now you've probably clicked on this video because you've been prescribed a statin, or you've been told that you need to start a statin, or you've been on a statin for a long time and you've been feeling many side effects and blame a lot of these symptoms on the statin, and you're really searching for some information. Well, hopefully today we can provide you with some useful insights, but of course anything we do discuss is purely general in nature. Liaise with your own cardiologist and doctor about what is the right treatment for you and your individual condition. Now, statin drugs remain one of the most discussed and also prescribed drugs in the community, and they are often hotly debated, and there are camps of people who are completely against statins, and there are others that are on them but rather reluctantly take them, or others that are on them but have some of the side effects. And in view of this and this constant barrage of information over the last several decades, statins have become one of the more hated classes of drugs. And I'm being honest and frank. As a cardiologist, as an interventional cardiologist that deals with patients on a day-to-day basis, one of the many discussions I have revolves around statins. So I want to get a few facts straight. Cholesterol itself is an essential part of our body, and it's critical for normal bodily functions. So we can't live, we can't survive without cholesterol. It is an essential part of our body. Statins are not the only way to lower cholesterol. So there are many other treatments that are available, some more beneficial than others, but there are also attention to lifestyle factors. And we know purely attending to some dietary changes, some weight reduction, some increasing exercise, increasing fiber intake in your diet can go a long way to lower your cholesterol naturally. So statins, like many other medicines that we use, are of course a multi-billion-dollar industry. And industry and various companies have obviously invested lots and lots of funds to undertake research so we can gain insights into how these drugs perform and what benefits they may have. So of course, having industry involved does create this sense of anxiety by people in the community. But I want to reiterate that the evidence is compelling that for certain people, particularly those that I see in my patient population, that is usually very skewed compared to for example, general practitioner or your general physician. I typically first see my patients when they've come into hospital and have had an event, have had a heart attack, I've put a stent in there. So in that group of patients, statins significant benefit at reducing the risk of repeat events. Clearly, less heart attacks, less stroke, less complications inside your stent, less risk of developing a condition called neoatherosclerosis, new plaque formation within stents. So there is definite benefit for those particular patients. Another fact, not everybody with a raised cholesterol blood level or reading needs to be on a statin. My practice is not to focus on just the number, but you have to put that value and that number in the context of what your risk factors are. Look at the bigger picture, and there are many risk-based calculators that can be used. I usually just rely on looking at the individual person in front of me and having a open and frank discussion about, well, what are your risk factors? Let's have a look. Do you have diabetes? Do you have high blood pressure? Do you have a family history of somebody, for example, less than 60 years of age, who has had a cardiac event, a cardiovascular event, a stroke, a heart attack, angina, needed bypass surgery, needed a stent? Are you a smoker? What is your weight doing? Is your weight higher? Your lifestyle, is it more sedentary? And you put that into the context of, well, what is our aim? Are we looking at stopping you from having another heart attack? Well, yes, then statins are beneficial. Or are we looking at stopping you from having your first heart attack? Here, we've got some time. And here is the patient population that has been often treated with drugs, with statins. It's often you have a blood test, cholesterol is up, here is the statin. It's often an easier way to conclude a consultation, take the statin, here you go, and I'll see you in a couple of months' time. Well, there is a lot to be said about that type of practice. And the aim, again, is to individualize. You need to explain to the patient. That's what the key of being a physician and a doctor is to explain to you why this statin drug may be beneficial, but to also explain to you why the statin may not be appropriate for you and what other tools can we use to give us evidence to decide and determine whether a statin would be useful for you. There's no doubt that statins are a well-studied drug. They have been around for decades. There are various different types of statins, and they all have their very individual differences, although this is a class effect of a drug, a statin group of drugs, but there are certain statins that may be tolerated better by some individuals compared to others that are not tolerated, or people might have more side effects. The most common being muscle aches and pains. There's no doubt that muscle aches and pain is a real phenomenon, but it's a common presentation. As we get older, muscles can ache, arthritis, muscular conditions, but being on a statin, there are people who typically, and patients of mine, that will report increasing aches, increasing pains, muscle stiffness, muscle cramps. And this can be a real condition where the muscle itself becomes quite inflamed, and fortunately that is very uncommon. A condition known as myositis, where the statin itself triggers off a breakdown of muscle because it does affect those particular enzymes involved in fat production and cholesterol production within muscles, within organs, and of course the liver being the primary organ where cholesterol is produced and statins work. We can also get liver issues or raised liver enzymes. Now, somebody who might have a high cholesterol, who might have diabetes, who might be a bit overweight, may also have a fatty liver. And a fatty liver itself can cause these abnormalities in liver enzymes. So you throw a statin in the mix, and that can often confuse the situation. Well, what's causing what? And there is this sense of, well, it's causing some side effects. I don't want to be on it. And I understand that completely. So the aim is to ensure that if you are prescribed a statin, that you would benefit. Your risk will be reduced being on a statin. And of course, the younger you are, the longer you need to be on this drug. Well, then I'm even more cautious about starting statins at an early age. Now, what is an early age? Well, of course, that's all very individualized. Again, it depends on the risks. You know, in your teens, 20s, 30s, that's a very early stage to be starting therapy with statins. And you've got to look at the individual risk and what are those risk factors that will predispose this person to developing hardening of the arteries as they grow older, to develop risks of heart attack, to risk of stroke, and statins may have a role. But it's not the first thing you jump into to prescribe a statin. So prescribing statins needs to be individualized, as I said, tailored, and it's not just about prescribing a statin at the highest dose you can and here it is and take it. And I often see that. And there are various statins. One atorvastatin, the highest dose is 80 milligrams. One rosuvastatin, the highest dose 40 milligrams. Simvastatin up to 80 milligrams and so forth. So, you know, that's not a wise move because patients are more likely to experience adverse events when you throw in such a high dose of a statin. And trying to control cholesterol and trying to reduce the risk of cholesterol building up inside the plaque in the walls of the arteries, well, that reduction doesn't happen in the space of a day or two or a week. That happens over several months and several years. So when we're looking at starting a statin, in patients who are stable, who are out in the community, who have risk factors and you're considering statin, my approach is to start at the lowest dose possible. 5 milligrams, 10 milligrams. And what about considering this? One thing that I do for many of my patients who might have an intolerance or who might have some concerns about being on statins or might have other muscular conditions and arthritis and so forth, and there's always a bit of a tendency that statins may trigger off or to cause more symptoms. Well, starting a statin, say, once or twice a week is a great way to start. Gets the body acclimatized to it. Initially, I might say 2 times a week. Then over 2 or 3 months, you build it up to 3 times a week. You know, one practice that I have with my patients is say, look, try it on a Monday, Wednesday, and a Friday. Let's do that for 3 or 4 months. Let's see what response. And I'm amazed to see how we can reduce risk, lower blood levels of cholesterol with only a small and a fraction of statin dose. Starting low, going slow, these are crucial and important considerations to ensure the body is able to tolerate these medicines long term. So, as I mentioned, my patient population is usually skewed. Many of my patients have had an event. And I would say to my patients, you are doing yourself a disservice by not being on a statin if you have had a heart attack, if you've come into hospital and you have had a stent, you've had a bypass operation, you've had a stroke, you've had problems with the blood flow to the lower limbs, to the legs, to the feet, peripheral vascular disease. So these are key considerations that in those patients, a lot has been said and written about statins, but the statins can reduce risks of recurrent events. And in some studies, this varies from 20% up to 30 to 40%. This is a significant risk reduction. But of course, statins are not the only thing we should be focusing on. We are looking about focusing on the overall well-being of our patient, looking at not only cholesterol and a number or blood level of cholesterol, which is meaningless on its own, looking at LDL, HDL, triglycerides, looking at blood sugar levels, insulin resistance, blood pressure. Controlling blood pressure in itself can significantly reduce the chances of having another event. Stopping smoking, reducing smoking, cutting it down. If we can't stop immediately, I understand it. Smoking is a tricky one, and we will have a separate video on that, but reducing smoking, that will also go a long way to reducing the long-term risk. Now, if you've never had any event, you're otherwise fit and healthy, and you go in and have a blood test and your cholesterol's up, that does not trigger off a prescription for statins. We look at your overall risk, we look at your risk factors, we make sure there are no warning symptoms that need further evaluation, but we also look at what role tests could play to improve our understanding about what your risk may be. And, two tests that I commonly refer to with my patients, they are often a crude way to look at whether there is plaque, cholesterol that has deposited around the arteries. Well, one is called a CT calcium score, a crude way of looking at calcium and the buildup of this around the arteries. If it's a high reading, then of course there's more likelihood that cholesterol and plaque has built up inside the wall of the arteries. And another test that can be useful is an ultrasound of the carotid arteries, a carotid Doppler ultrasound. We often don't expect major blockages there, of course, in people who are asymptomatic, but it will give you information about whether there is mild to moderate plaque already built up in those arteries. And that then may prompt us to say, well, look, there is some plaque that is built up. We are fortunate to not have had an event thus far. Well, how do we reduce things further? Looking at statin as one particular option, but not ignoring things like blood pressure, cholesterol, diabetes, smoking. They are the reversible risk factors that we can address. So when we initiate statin therapy, we, as doctors and of course patients, like to see the number. These numbers, these values of cholesterol, of LDL, of HDL, total cholesterol, and what's happening with that. And we are gratified by seeing the reduction. But it's not all about just getting that number down. There are some additional benefits the statins have beyond just lowering the blood LDL cholesterol. And one of the key ones that I also explain to my patients is a role in reducing inflammation. Now, you might have heard, you might have read, you might have seen online about the role of inflammation. Inflammation is a condition whereby the body produces active cells that essentially target itself, and that can trigger off the development of plaque building up within the arteries of the heart. And inflammation is an important factor. Well, statins, in addition to lowering the blood level of cholesterol by working, predominantly in the liver on the blocking certain enzymes that are used in the pathway of cholesterol production in our body, can also reduce inflammation or suppress inflammation. And one of the key I like to show here is in this model. When you look at a plaque, and here's a large plaque that is built up in the wall of an artery in this model, one bit of tissue that sits on top of this plaque, and here depicted as white, is something that we know as the fibrous cap. And that fibrous cap is a rim of tissue that, as cholesterol builds up and worsens, and as inflammation increases, that cap gets thinner and thinner and thinner and becomes more vulnerable to bursting, to rupturing. And that's what causes heart attacks. So it's not only the blockage and the amount of plaque, but it's that rim of critical tissue that sits on top of that plaque that's stopping that plaque from rupturing and getting out. Well, there are many inflammatory cells in that cap. One type of cell called macrophages, and these cells become active, and they can become active, and then that cap becomes thinner and thinner and thinner, and it bursts, and that's what causes heart attacks. Well, statins have a very good benefit at reducing that localized inflammation. And by reducing inflammation and potentially helping to make that cap thicker, we can reduce the risks of that cholesterol bursting and causing complications. And I've seen that with my research, using this sophisticated camera to look inside the arteries of our patients. When we do an angiogram, an invasive test, and we can look at this cholesterol and this plaque, and we quite clearly see it here. And this is one of the front cover of my PhD thesis book, but you can see quite clearly this rim of tissue here has become so thin in this patient that right at this shoulder region of the cholesterol, it has burst. and all the muck and all the plaque and all the clot now is starting to form inside the artery, causing a heart attack. The statins can improve that thickness and reduce the risk. So there's no doubt there is a benefit. So my approach, some practical tips. I choose my statin wisely. And there are various statins, as we mentioned, and some may be better tolerated than others. Sometimes it's trial and error, unfortunately. Trying one particular statin, starting at a low dose, starting perhaps not even every day, and seeing how the body adjusts, how the body tolerates. When there may be side effects, muscle aches, pains, cramps, they are the most commonly reported side effects. And the mechanism is very poorly understood as to why that might be. There is some consideration that it may have a bearing that statins do impact some of the muscle enzyme processes that occur by blocking certain enzymes. And then we get this deficiency in ubiquinone or coenzyme Q10, you might have heard. There is some theoretical benefit there to supplement natural coenzyme Q10 or ubiquinol when you are on a statin because of that potential risk and disruption that statins may cause in the muscle. Simple things like keeping yourself hydrated. If you are active, sometimes a little bit of magnesium supplementation may be something you want to also discuss with your doctor to see whether that may be beneficial. And these side effects initially, if we have that low and slow approach, often do not become a major burden for our patients. Now again, there are exceptions that people who cannot take statins, and I would not, try them. We've tried one or two and they can't tolerate it, they're intolerable, then we've got to look at alternatives. And there are alternatives, and we'll have separate videos on what some of those are, including one called ezetimibe. There are some simple muscle enzyme tests that can be done on blood testing, and also liver function tests when patients have been on statins. And I will normally consider doing that, after a month or two of statin therapy, or at any time sooner if there are symptoms reported. And another tip is not to make the statin the focal point. We tend to get focused too much on the statin and how we hate being on this drug, how we've read it does this and how we've read it does that, and how big business and big industry is involved. If you have adequate education and information from your treating team about why it may be beneficial for you, you are more likely to be more satisfied and comfortable that the statin is going to help reduce your risk long term. So this has been a hotly debated topic. I don't mean to try to provide all answers to statins, and of course there will be many comments about what they feel about statins, and I understand completely. And the statin should not be the focal point. Does my patient actually need to be on a statin in the first place? Again, that's the key question. And when they do, and if they do, and if we can't address things with simple lifestyle changes, which are easy to say that we're going to implement, but obviously sometimes hard to actually do. But if we can't achieve with those measures, and there is a need and there is a risk reduction available for the patient, then statins may be beneficial. In the acute setting, when somebody has had a heart attack, well then there's definitely no doubt that the evidence is strong. Heart attack, stroke, bypass, stent, other risk factors, diabetes, smoking, high blood pressure, there are benefits there. But if you don't have any of those, but you've just got a high level of blood cholesterol, not essential that you start off with a statin in the first place. Undertake some lifestyle changes. See how you go over the course of 6 months, 12 months. Try looking at what tests might be available to give us greater insights into, what is the need pressing that you should be on a statin? Or can we just monitor, watch and wait? So hopefully you found some of those points useful, interesting, maybe controversial, but I am speaking, of course, as a health professional who deals with patients, and my interest is in ensuring that the best outcome can be achieved for my patients. Always discuss with your own cardiologist, with your own general physician, general practitioner, when you're looking at your own risk profile and what therapies and interventions may be necessary. And until the next video, bye for now.